Okay, good morning, everyone, and welcome to our Friday morning program. Um, it is really one of the wonderful privileges that I have in academic medicine to have the opportunity to introduce and to honor one of my friends and colleagues for whom I have tremendous respect as a scholar and as a surgeon. Dr. Jeremy Freeman, who has presented on several occasions in the past, is joining us this morning. He is a native Canadian who has spent his entire medical career in Toronto, where he completed 2 fellowships, one in head and neck surgery, and quite remarkably, a second fellowship in radiation and medical oncology. There are very few head and neck surgeons across the world who have that type of breadth of experience and breadth of training, and makes him incredibly unique. He is currently the Tammy Leitner Dynacare Chair in Head and Neck Oncology at the University of Toronto. He is also, very importantly, the director of a very esteemed University of Toronto Head and Neck Oncology Fellowship Program. He has had a very stellar academic career as an author, as well as a researcher, a lecturer, and perhaps equally importantly, as a mentor. He has been actively involved in the thyroid international community as a valued lecturer on all aspects of thyroid surgical management. Jeremy has a wealth of personal experience that gives him a very important role as a teacher to all those who are fortunate to listen to his lectures, as I have been and have learned tremendously from him during the course of my career. This is indeed the second time that he has given an invited lectureship on this platform, and has also presented during our tumor board sessions. Before I turn over the program, I would like to share a quote from Dr. Greg Randolph, who called me yesterday evening. And what he had to say was that Jeremy Freeman has forgotten more about thyroidology than he, Greg Randolph, will ever know. And so with that, I, as always, encourage questions. This is a unique opportunity for everyone to pick his brain about topics related to thyroidology. And Dr. Freeman, welcome, and thank you for joining us.
Thank you, Mark. I just want to share my screen here.
All set.
Okay, thank you very much, Mark, for that kind introduction. This is my own title slide, which I've put in just to remind me to remind everybody tuning in about the upcoming World Congress of Thyroid Cancer for virtual meeting in April. Mark will be one of our featured guests, and we look forward to all those interested registering. This will be a virtual meeting, of course. I have no disclosures. Just want to put up this slide again. There was a discrepancy in the voting. I think the election was rigged. I don't think the right candidate was voted in. And there's this mistaken concept across North America that just because you get the most votes, you win. I don't agree with that, much like one of your former presidents. I'm going to talk about my experience over the last 40 years in practice, more than 40 years. This is my timeline. I hope you can see that. I started in 1967. Can you believe that? And I started as a staff head and neck surgeon at Mount Sinai in Toronto General in 1980. Let's go back and see what is happening and what was happening in 1980. President of the United States was Jimmy Carter. You may or may not remember the Iran hostage crisis, where a Canadian diplomat spirited out 6 American diplomats from Iran. His name was Ken Taylor, and I developed a bit of a friend relationship with him. A very nice, gentle man. Israel and Egypt established diplomatic relationships. Rubik Cube was invented. Indira Gandhi was the PM of India. Pierre Trudeau was elected as PM of Canada. And there was a worldwide boycott and disdain for Russia. There was a worldwide boycott of the Summer Olympics. And why? Because the Russians invaded Afghanistan. Can you believe that? Rosie Ruiz won the New York Marathon, except she took a subway for half of it. Pittsburgh Steelers won the Super Bowl under Terry Bradshaw, Lynn Swann, and the Steel Curtain. The LA Lakers under the stars of Kareem Abdul-Jabbar and Magic Johnson won the NBA championship. Ronald Reagan was the Republican nominee for the president. Lech Walesa led many strikes in the Gdansk shipyards, which started the Solidarity movement and went on to lead to freedom for many countries in the Eastern Bloc. Terry Fox was forced to end his marathon of hope because of his recurrence of cancer. The best movie of the year at the Academy Awards was Kramer versus Kramer, and won individual awards for Dustin Hoffman and Meryl Streep. The Phillies won the World Series. The Islanders won the Stanley Cup. And prominent people who died were Jesse Owens, Jean-Paul Sartre, the existentialist, the movie director Alfred Hitchcock, Joseph Tito, who unified Yugoslavia, Henry Miller, Peter Sellers, the actor, one of my favorites, Steve McQueen, and John Lennon. Terrible death. So let's go on. Let's go back to 1980. A 55-year-old man comes into my office with a 3-centimeter mass palpated in the right lobe of the thyroid, sent by his family doctor. There were no risk factors, no compressive symptoms. Exam was negative, vocal cords mobile, TSH normal. An ultrasound showed a 3-centimeter mass with no other features of note. Nodes were negative. He may or may not at that time have had an FNA. FNAs were not prominent. We use clinical factors to justify whether he had surgery, whether he should have surgery or not. So there was age, gender, and a solitary mass. Good reason for surgery in those days. He would have had a total thyroidectomy. He had a 3-centimeter papillary carcinoma with no adverse prognostic features. In those days, there were no standardized synoptic pathology reporting. He would have automatically had RAI, and his follow-up would have been varied. Some people would have just done a physical exam, some an ultrasound. There were no biomarkers in those days. He may have developed a paratracheal node, which may not have been detected, and his outcome probably would have been great. Fast forward, same patient, a 55-year-old male again, had a routine ultrasound because of neck pain. Isn't that why you do ultrasounds nowadays? And this time, he may have had an ultrasound-guided fine needle aspirate for his neck node. If it was atypical, he may have had options to go on to molecular testing. If it was malignant, he would have had less than a total thyroidectomy, according to most guidelines. And his pathology in a synoptic report would have been reported as papillary thyroid cancer, and he probably would not have had radioactive iodine. We'll go on to see why. He would have been staged in a 3-part fashion. He would have had a TNM AJC type of staging, a stage 1, where his disease-specific survival would have been 98 to 100%. His ATA risk for recurrence would have been low, and his ATA response to therapy would have been excellent if his TG were undetectable and there was no anatomical evidence of tumor. Therefore, no completion thyroidectomy. He would have been followed with serial ultrasounds and thyroglobulin if a total thyroidectomy were done. And perhaps if a paratracheal mass were found, say 1 centimeter, he may have had an FNA that found PTC, but then what? Then the argument begins. So let's examine these things. So what do I think are the important issues that have evolved over the last 4 decades? Well, I think one of the most important, if not the most important, is an authoritative body or bodies have been established to codify in an evidence-based fashion guidelines for management of all facets of endocrine surgery. And these provide optimal management protocols, standardized management, They promote cost effectiveness, and they constantly change commensurate with evolving evidence. What are these? Well, you have to have a playbook, just like Tom Brady has a playbook and many NFL teams have playbooks. And we look at this playbook for guidance in management of well-differentiated thyroid cancer. The one I use is the American Thyroid Association, but and as an aside, they're always evolving, they're always changing. The last one was 2015, which was published in 16, but more questions arise, more references, more knowledge becomes available to us in that realm. There are the British Association guidelines, there are the Korean guidelines, there are the European Society for Medical Oncology guidelines. There are many guidelines, they're much the same. So this is a project for some up-and-coming young person. What about unifying these guidelines to give a worldwide guideline? Is that a possibility? But guidelines are important for us. There have been refinements in risk stratification for better defining those patients who have a propensity for developing cancer. And early on, those guidelines, as are shown here, involve patient factors such as age, gender, and so on, tumor factors such as hardness, fixation, and so on, ultrasonographic findings, and pathological factors on fine needle aspirate. We first looked at the Kinney criteria, which then evolved into the Bethesda group of guidelines. We'll talk a little bit about that going on. So now we have a roadmap or a number of indicators for surgery that have a propensity for cancer. Now we have to stage. So early on, we started off with pre and post-operative staging systems that were very primitive. Basically, there are three types of cancers. There are good, there are bad, there are ugly ones, according to the Sergio Leone film. But as time went on, in the 80s, 90s, and so on, certain staging systems evolved. And I thought the best one in those days was the Mayo system, MESIS system, based on metastases, age, completeness of resection, invasiveness, and size of tumor. And this gave us a roadmap of prognostication and indication for whether or not radioactive iodine should be applied. Now we've got three staging systems. We're pretty far ahead of most cancer staging systems. So there's the AJC-UICC that predicts mortality. There's the ATA that predicts recurrence, and the ATA response to treatment. And these are in a constant continuum being changed to conform to the evidence of the knowledge and evidence of the day. The ATA guidelines started off in 2009 and were very rudimentary, as you can see here. And there was no coherence to those guidelines, and the staging system did not really reflect the veracity of the rate of recurrence of these tumors. So they became modified, and attention was then placed to lymph nodes. All lymph nodes are not the same. So that was applied to this set of guidelines. They also paid attention to age, invasiveness, and cell type. So from this risk stratification paradigm came this 8th edition of the AJC TNM classification of stages, which paid attention to age and metastases. And this was more coherent. And this was this blended better to the disease-specific survival. We were able to predict much better given these changes that were made in the fundamental systems that started out. The ATA also applied these guidelines and these changes to the risk of recurrence. So again, a more coherent risk recurrence strata were evolved, taking into account that not all lymph nodes were the same, and there were various higher risk variants of papillary thyroid cancer, such as tall cell variant. We've got to thank Mike Int'l for developing most of these risk stratification paradigms. And Mike also evolved the response to treatment, which is an ever-changing over time paradigm. And there are 4 basic classifications within this response to treatment that came out in 2016. The excellent response, where there was negative ultrasound and undetectable TG. There was an incomplete biochemical response with higher TG, incomplete structural response with some evidence of disease on imaging, and an indeterminate response where there's might be a little bit of elevation of TG and maybe or not a anatomical presence of recurrence. And these allowed us to take certain steps in determining whether or not intervention should be applied or not. There's a picture of handsome Mike in between 2 other people. What I want to take a few minutes on is the greater role of sophisticated ultrasonographic technology and interpretation. I owe a lot to Bob Sofferman, the late Bob Sofferman. Here he is beside Rich Robin. Bob inspired me to become an ultrasonographer. And he was like a voice in the wilderness, and gradually people began paying attention to him in the 80s and 90s. Ultrasonographic technology was developed by an obstetrician and an engineer in Britain. And basically the premise of ultrasound are 1 to 5 megahertz emitted from a probe. And these sound waves take advantage of the boundaries between the densities of soft tissues. And some get transmitted and some get reflected back. They're picked up by a processor, and an ultrasonographic picture is shown. Now, traditionally, this has been the realm of radiologists, but as time has gone by, all sorts of specialties, including our own, have become interested in ultrasound. I can tell you right now, I don't think you can be an adequate endocrine surgeon without a sound knowledge of ultrasound and doing your own ultrasound. You must do your own ultrasound. Why? Because it gives you real-time anatomical information. It detects metastases in most cases in the lateral neck. There's an ease of result reporting, and I'll show you my homunculus format. You can assess vocal cord mobility with an ultrasound. You have more confidence in your FNA results when you do them yourself. You reduce unnecessary surgical procedures, and I'll show you numbers to validate that. You're able to perform alcohol ablation, and it's one-shot stopping. Now here's a graph that many of you have seen, the exponential rise of new cases of well-differentiated thyroid cancer. So every maneuver that we institute has unintended consequences. And the unintended consequences are that everybody's getting ultrasound. There may be a financial gain from this. And the number of cases reported in the United States and Canada every year is escalating exponentially. Yet the number of deaths remains static. What that tells me, and what my colleagues tell me who do number crunching, is that this is a classical graph of overdiagnosis. And no doubt ultrasound is the culprit. As I said before, anybody with any symptom in the head and neck gets an ultrasound, and hence these dormant papillary thyroid microcancers and small cancers are getting discovered. What is the implication of that? Well, in a previous publication, a quarter of the people of Ontario harbor microcarcinoma of the thyroid, or some macrocarcinomas. So if there are 13.5 million people in our province, are there really 3.24 new thyroid cancers a year? Similarly, in the US, if there are 330 million people, are there 79 million new cancers in the United States? Well, you could make a whole burgeoning industry out of this. The new cases reported in the US Cancer Society stats were about 64,000 per year. The problem is, which ones do you pay attention to and which ones don't? And that's a conundrum and, again, an unintended consequence. What we've done in Ontario, our province, is try to educate patients to ask their physicians about any tests. Do I really need this test or treatment? What are the downsides? What are the other options? And what happens if I do nothing? These are questions that should be asked to their physicians. This may eliminate some of the excessive ultrasonography. This has also led to a liberal approach to fine needle aspirate. And fortunately, the ATA and the other authoritative bodies have set down guidelines for doing biopsies. We can't biopsy everything, otherwise we'll again inundate our system. So we've tried very hard to set down guidelines for fine needle aspirate indication. I like the ATA guidelines because they're simple, they're easy to read, and they're easy to apply. So basically, you don't biopsy small tumors, you don't biopsy cysts, and you don't biopsy simple spongiform nodules. So we've got a risk stratification scale of what to biopsy or not to eliminate this inundation of papillary thyroid cancer. I like reporting these on what I call a homunculus scale. It saves you a lot of time reading excessive verbiage. You see a graphic depiction of the nodules in the thyroid with a description right on the sheet. This is something I stole from the Mayo Clinic. I'll show you their homunculus in a second. This is an important slide. This is what my practice has evolved into over 4 decades. My biopsy-proven cancers went from 30% way back when to about 4 years ago to 60%. I'm betting now it's about 80%. 80% of my cancers that I operate on are biopsy proven. What I've also done is I've not operated on all atypical nodules. Now we offer patients a 3-option choice, and some of them take, in lieu of surgery, some of them take surveillance, because we now know the biology of these tumors, which is slow growing and indolent, and some of them take molecular testing. This has eliminated a whole bunch of cases that we've heretofore operated upon. We've also eliminated the pure clinical decision-making of ostensible benign disease to do surgery. For example, I follow a lot of big tumors. I follow a lot of elderly people. I follow a lot of men, and this has reduced our operating time, our operating incidence dramatically. So I'm sorry to the surgeons, but using these evidence-based paradigms, we've eliminated a lot of patients who shouldn't be operated on, and our yield for surgery is quite high because most of the ones we operate on now are biopsy proven. Also, ultrasound allows us to plan our surgery. Obviously, we get a great roadmap of what operation to do and how much, the extent of the operation that we need to do. Ultrasound biopsy is quick, it's easy, it's low morbidity, it's cost effective, and it's informative. It's usually done in the clinic setting as a patient sitting in the chair. The instrumentation is rudimentary. All you need is a needle, some local. We put our syringe on IV tubing. We have a second person drawing on it, although most of the effluent comes into the tube in capillary action, and we put it in cytolite. Here's a picture of how we do it. Here's our homunculus reporting system. This is the one I stole from the Mayo folks. They like to map out their metastases. Here's a picture of Clive Grant, and they pay a lot of attention to their own ultrasounds. Again, the unintended consequence is the high incidence, the exponential growth of thyroid cancer, and we have to address this. as too many people, well, let me quote myself. I like quoting myself. So now we're in a situation where we're identifying more patients who may not need treatment, and we may be over-treating those patients who don't need treatment at all, not to mention those patients with treatable cancers who are already being over-treated. And we'll elaborate on that in a minute. The American College of Radiology has come up with a scale in order to predict patients who may have cancer and to reduce the number of biopsies done. This is called the TIRAD system. TIRAD means Thyroid Imaging, Reporting, and Data System. What they do is they've taken 5 qualities: composition, echogenicity, shape, margin, and echogenic foci, and assigned a numeric value. And at the end of the day, if they overstep a numeric value of, say, 4, 5, 6, those are suspicious nodules that should be biopsied. They are trying to cohere to the Bethesda classification shown here. We'll talk about that in a minute, and try to get as close on their biopsies to suspicious or malignant. Alas, this has not panned out. The overall predictability of TIRADs is only 35%. According to Middleton, Modi has found an even lower rate for TIRADs 4 and 5, which compares to Middleton's 3.3 and 23%. Padya has looked at the ATA classification, just to be fair, and found that their positive predictive value for cancer is quite low as well for their 4 and 5 classifications, and that is 12% and 28%. Middleton has also found that TIRADs, to its credit, avoids more FNAs than ATA. So we've got a lot of work to do there. And there's the risk classification scale, again, for risk status scale for the ATA classification. Now, surgeons are doing more and more ultrasounds, and we're seeing more and more of these types of graphs. And I turn your attention to this graph where the efficacy of the surgeon versus the imager in overall accuracy in getting positive diagnoses or adiagnoses is pretty much equal, and should be to a good ultrasonographic program in the realm of 90%. One of the studies that we did back in 2013 looked at a large number of ultrasound-guided fine needle aspirates, and the issue that came out there is don't give up at the beginning if you're getting low yields. There's a learning curve, and it takes about 300 cases to get facile in this realm. So again, to reiterate, we get real-time anatomic information from ultrasound. You can detect lateral metastases. You can easily read the report in this homunculus format. You can assess focal cord mobility. We have confidence now in our FNA results because of our surgical expertise. We reduce the number of unnecessary surgical procedures. I often get patients sent to me with lumps in the neck where the outside ultrasonographer sees a lump, but in fact, these are diffuse lumps of thyroiditis that don't need biopsy and surely don't need surgery. We can do our own alcohol ablation, and it's one-stop shopping. Just a brief note about imaging as it's evolved over the last 40 years. Cross-sectional imaging has become more sophisticated, resolution is better. The introduction of 4D CT has allowed us better depiction of disease, and certainly PET scanning has helped us in detecting metastases and recurrences. PET scanning didn't exist when I started out. So we've had improvements in cytological and pathological standards and their application, and this has allowed a focused approach to intervention and subsequent adjuvant treatment. One of the things that I feel is important that has been elucidated by sophisticated pathology analysis is the NIFP, or the non-invasive follicular variant of papillary thyroid cancer. Up to now, we've been giving ourselves high fives. We've had these low grade, what we think are cancers because they have kidney features of pathology, pathology on fine needle aspirate. But these cancers are not infiltrated. They're all encapsulated. They don't have a high mitotic activity. They don't infiltrate. And are these cancers really cancers? Well, you know, here's a path slide of one of these things. They don't really have true papillae. They're encapsulated. And my colleague, Yuri Nikiforov, feels that these probably are not true invasive malignancies. They're probably pre-malignant. And before we give ourselves high fives about the great results we're getting, almost 100% cures, we've really got to examine whether or not these are malignancies. Although some of them have RAS and RAS-like mutations, and surely they have many of the kidney features of malignancy, but are they really malignancies? And this requires further work down the road. Now, one of the things we've done that I think is very welcome is classifying and standardizing pathological variants. And we owe a lot to Ed Seabass from Harvard and his group for codifying various conglomerates of cells seen under the microscope and classifying them in the Bethesda classification. One of the important things about Bethesda is that it's purely subjective. It's reported through the eyes of the pathologist, which may be variable. And the other important aspect of Bethesda is one must know their own malignancy rates in their own institutions, which is variable. And if you look at ours, and we've audited all of ours, you can see that Bethesda 2 is malignant in less than 0.5%, so we believe that. Bethesda 3, or the atypical, or 4, the follicular ones, are pretty high. They're on the high end of the spectrum around the world. Bethesda 5 is 90%, and Bethesda 6 is almost 100% in our institution. We've gained a better understanding of the biology of these tumors, and we looked at the rate of the rate of malignancy of well-differentiated thyroid cancer. In my series, one year I did 258 of these cancers over 24-month period, and the vast majority of these cancers are papillary. In the old days, we thought that follicular made up a good percentage, but follicular are quite infrequent. What was called follicular were probably follicular variants of papillary. So what is the knowledge of the biology of these tumors given us? It's given us the ability to surveil atypical lesions, surveil small tumors, small papillary tumors. We've managed low-risk tumors conservatively in pregnancy. We've surveilled small recurrences, and we've de-escalated the extent of thyroid surgery. Now, Ernie Mazzaferri, my good friend, published this Air Force series of 576 patients and basically found through this very flawed series that the best treatment for well-differentiated papillary thyroid cancer were total thyroidectomies, giving thyroid hormone suppression, and RAI. Well, this was a flawed series, and we had to disprove it. It took us almost 3 or 4 decades to do that. And one of the things that we disproved, that hemithyroidectomy was probably as good a treatment as total thyroidectomy. We do only 2 operations. We do hemithyroidectomy and total thyroidectomy. So the logical reasons to do a less than total thyroidectomy would be if the results were the same and the complications were less. And there have been many series. Here's one from Memorial by Ian Nixon, which basically showed when comparing lobectomy to total thyroidectomy that the rate of recurrence and survival was the same. Similar series for Mendelssohn using SEER data showing the survival and recurrence rates were the same. Here's a series from Zeleny from, sorry, I can't remember where he was from. Sorry, his name is Zeri, not Zeleny. And he analyzed NAS data and found that the complication rate and length of stay was much less than total thyroidectomy with unilateral thyroidectomy. So this was then codified into the guidelines and showed us that less than total thyroidectomy works just as well as total thyroidectomy, but they're very clever and they put in a little clause there that said, I guess for the old timers, that a bilateral procedure is still in play. So who deserves a total thyroidectomy? Well, big tumors, multifocal tumors, high-grade tumors, ones with nodal metastases and extrathyroid extension, and those tumors that we attribute to genetic abnormalities, such as patients who have received low-dose radiation, dental workers, the Chernobyl population, Filipinos and Filipinas, those with strong family history, and those with syndrome like familial polyposis, Cowden's, and Hendricks. Of course, you're not going to do a less than total on these types of patients, and that goes to show that you've got to show some sort of perspicacity in dealing with these huge tumors. We've also learned that it's important to identify the external branch of the superior laryngeal nerve, and this has given us less dysphonia. We owe Claudio Cernea a debt because of him bringing this to our attention. And right now it takes, several seconds just to identify this external branch of the superior laryngeal nerve. Our knowledge of biology of this tumor has allowed us to surveil tumors now. And a lot of this work has come from the Japanese group, namely the Kobe group, headed by Professor Ito and Miyachi, who in their classic publication of many patients with less than 1 centimeter tumors who they followed, showed very little in the way of growth and very little in the way of development of metastases. But the important thing is those that were followed and ultimately had to have surgery showed no difference in their ultimate outcome. So this is here to stay. Now, again, I just want to emphasize that our hesitation to operate on atypical lesions and giving patients a choice of following atypical lesions in addition to molecular testing and surgery has diminished our surgical rate. Our reliance on clinical features has reduced our surgical rate. And this is basically our knowledge of the biology of this tumor. And most of our tumors now are operated on for positive biopsies. Just a word about molecular testing. This is our risk stratification scale. I just want to go through very briefly the concepts of molecular testing. The group in Pittsburgh, headed by Yuri Nikiforov, have done a yeoman's work in showing us that we can detect mutations, fusions, and expression in thyroid follicular cell analyses. Here's a nice picture of Yuri and me. They extract DNA and RNA. They put it in a medium. And the ones that we really pay attention to are the indeterminate ones. Here's the platform that Yuri uses, 56 genes shown here for analysis. And here is a risk stratification scale again for the relative danger of the various gene mutations that are found. And obviously BRAF, RET, PTC, and TERT are the real boogeyman boogeymen here in cancer probability. So what I think is going to happen is, just as we do risk stratification for clinical features, there's a risk stratification scale now that Yuri is developing. And I think in the future, what we're going to be looking at are, rather than the eyes of the pathologist seeing cellular features, we're going to be doing molecular signatures and making our diagnoses and prognostications by the gene profile. And here we have the relative positivity of cancer. And the ones we're interested in, again, are the intermediate ones and ones with RAS, BRAF, and multiple mutations. You can see that the positive predictive value is quite high. So this is here to stay. We also are indebted to Tom Giordano over the last several years, who has depicted the Cancer Genome Atlas and has helped us with identifying various high-risk cancers, which have treatment implications later on. So post-op surveillance has been standardized: clinical exam, TG, and ultrasound. We've developed alternate approaches to these small recurrences. 25, 30 years ago, I used to operate on all of these, and I've accumulated a huge database of about 350 patients with these small recurrences shown here. But now we've applied rules and a playbook to which ones we can follow, the less than 1 centimeter ones, which ones we should biopsy, the greater than 1 centimeter ones, or the multiple ones, or the ones that patients want us to do. So in addition to reoperating on these things, which is fraught with danger, we now have the ability to alcohol ablate and observe these small recurrences without any detriment to the patient's survival. I don't know much about radiofrequency ablation, and this is a new modality that's come on the stage and requires further trials to see what efficacy it really has. So again, we used to apply RAI to everything. And it became very apparent, according to the Mayo people and even our own Anna Saka, that there was not a real evidence-based good reason to apply RAI to early stage well-differentiated cancer. And here's a short study that was done by Ian Hay many years ago, but it tells us volumes about low-risk cancer, whether to ablate or not. They took a large number of patients of early cancer, MESIS less than 6, low-risk cancer. They gave them ablation and looked at their survival, and then they didn't ablate a number of them, and guess what? Same curve. They did the same thing with MESIS less than 6, and and looking at recurrences. Here are the ones that have been ablated, and guess what? The ones that weren't ablated, same curve. They looked at ones with lymphatic involvement in the central compartment. Here's the ones they ablated, almost 100% survival. Here's the ones that they didn't ablate, almost 100% survival. And then the ones with known metastases in the central compartment. Here's the ones they ablated. We know that they're going to have some impact on their recurrence rate. And here's the ones that they didn't ablate. In fact, they did better. So one needn't ablate all well-differentiated cancers. We did a short study on TG modulated decision-making and looked at patients that had TG less than 1, 1 to 5, and greater than 5. We didn't ablate these. We did ablate these ones greater than 5. And in the middle, we made a decision based on their clinical activity and their clinical results. And lo and behold, none of these patients recurred. So we apply this as well to our post-op patients as to whether or not they need ablation. And when we used our paradigm compared to the ATA paradigm for ablating with RAI, we found that whereas 57% of patients required ablation according to the ATA rules, our patients only required 10% of our patients required ablation. So there have been major breakthroughs in systemic treatment for well-differentiated thyroid cancer, which have gone on to be poorly differentiated or bad actors or ugly ones, as we used to call them. And I think this is one of the great futures of the management of thyroid cancer, in that we can now do targeted treatments according to their sequencing and their gene profile. And here we have a depiction of the treatment of anaplastic carcinoma, which has shown great strides in the last 2 years with the application of systemic treatment and longer life expectancies. So these folks are the folks that are really going to make a difference, I think, in the future. So just to wind up, what else has happened over the last 40 years in terms of innovative procedures? Well, we've had minimal access procedures come to the stage. Some of them are good, some of them are not so good. Some of them have stayed. For example, procedures to avoid neck scarring, such as trans-cervical through the lower lip procedures. Some of them have not stayed, such as the MEVAT procedures. I don't think they're very popular nowadays, especially in North America. And one of the things, Mark would be interested in this, and Mark has been a pioneer in this, is aggressive procedures to the laryngopharynx that have allowed greater life expectancies with advanced tumors. We owe a lot to Hermes Grillo, who died very tragically several years ago in a motor accident, who told us we could do large procedures on these patients. We could ablate parts of their larynx, parts of their esophagus. We could pull up their trachea to close these defects with very good overall results. And Mark again should be thanked for showing us the way, the pathway for managing these patients. So just to close off, what other things have evolved over the last 40 years that have really changed the landscape of the management of thyroid cancer? Surgically, we've had great energy alternatives that have cut down on bleeding, such as the ligature, the Thunderbolt, the harmonic scalpel. Greg Randolph has been a great pioneer in the realm of nerve monitoring. Robotic surgery has made its way, and some procedures are amenable to robotic surgery, again, such as the trans-lip, trans-cervical approach. We've adopted minimal access mediastinal approaches for small mets in the mediastinum through the neck, which allows us not to do sternotomies and massive resections. We can thank our Japanese colleagues for teaching us about nerve reconstruction, especially ANSA to recurrent nerve reconstructive techniques. Greg has been a huge proponent of promoting fiber optic laryngoscopy in all pre and post-op patients. Several groups have evolved autofluorescence and ICG angiography to identify parathyroids. It's going to be a huge boon to the management of thyroid cancer and parathyroid identification. RFA is still in its infancy, and I'm looking forward to its application. Obviously, recombinant human TSH, both for therapeutics and diagnostics, has been a huge boon to the management of thyroid malignancies. Octreotide, which I learned from Clive Grant, has been a great help to me in managing chyle leaks. And I haven't operated on a chyle leak in 20 years because of conservative techniques, and also the use of total parenteral nutrition in the management of these. And lymphangiography for chyle leaks has come to the fore. And we've had a few patients that were recalcitrant to any treatment that the lymphangiographers were able to cannulate their lymphatic system and obstruct the lymphatic system and stop the chyle leaks. A great technology. So have we made a difference over the last 4 decades? Yes, we have. And I've just shown you how. But we've got a ways to go. We've got a ways to go to manage unintended consequences, such as the huge onslaught of thyroid malignancies that probably should not be treated or overtreated or even found. And these are some of our own makings. And there are other issues. We've got to be able to deal with the huge onslaught of fine needle aspirates that are finding many of these tumors. We've got to set down guidelines for reducing the number of fine needle aspirates. We've got to educate our family docs in not sending patients for ultrasound. And we've got to see where our systemic treatment is leading us, because I think this is going to be the new landscape and the new horizon for management of thyroid cancer. So I'm going to stop right there, ladies and gentlemen, and I hope we have some time left over that I can answer some questions.
Jeremy, thank you very much. That was just an absolutely spectacular and, as always, both entertaining and informative. Your background is reflective of the fact that I feel like I've toured the globe, if not the galaxy, in this lecture, which is just absolutely terrific. Before I get to questions, I just have to ask, did you solve the Rubik's Cube back in 1980?
I am so pathetic at the Rubik's Cube that I'm embarrassed to answer that question.
Okay. Okay. Well, we, on that note, one of our attendees has asked the question about geographic location and how that influences your management of thyroid nodules, in particular related to tumors arising in the isthmus. And you did, along the way, note that you do 2 operations. One is a lobectomy, the other is a total. Is there ever a role for an isthmusectomy?
Yeah, that's a great question. I do not do that operation because I'm kind of a control freak when I do surgery, and I want to see a nerve, whether it be one or both nerves. And when you're doing an isthmusectomy, there is a time when nerves can be in an aberrant location and be on top of the trachea. I've seen that many times. If you do an isthmusectomy, there is a risk of injuring that nerve. So when I approach an isthmic tumor, I approach it from one side or the other, so I know where that nerve is.
Great, terrific. So let me ask you, how well is active surveillance accepted in your practice? Is this a tough sell? That's question number 1. And number 2, give me your perspectives on how far you think this management approach will go. Namely, how big of a tumor do you think we will settle in? And obviously, there are a number of variables associated with that. But just tell me where you think 5 years and 10 years from now that approach to biopsy-proven or suspicious thyroid nodules will take us.
Yeah, so it's a relatively easy sell for us, and I have a whole bunch of patients who I'm surveilling myself. It really depends how you sell it. I put it on an equal, reasonable scale as surgery and molecular testing. Many of our patients can't afford molecular testing because it's not a third-party accepted expense, so they have to pay out of pocket. So the question really comes down to active surveillance or surgery, and a good number of our patients accept it. I can't give you an exact percentage, Mark, but it's significant. These are patients that don't want an operation. As to the second question, how far out can we take this thing? Well, you know, the Memorial folks are doing 1.5 centimeters and getting pretty good results with that. Whether we can push the envelope out to 2 centimeters, I'm not sure. Obviously, it's got to be part of a trial. It's got to be evidence-based, and we'll see how it goes. You know, I'd be anxious to see if a 2 centimeter lesion can be surveilled.
Great. And let me just ask you, in the moments remaining, we've gone from very small tumors to those aggressive tumors. Have you had any experience in the burgeoning field of neoadjuvant therapy for those tumors that in differentiated, not in anaplastic, and using neoadjuvant therapy prior to embarking on surgery? And what are your thoughts about that?
Yeah, no, we haven't gone that route. I understand some institutions have. Be interested to see what their results are.
Okay. And in the minute remaining here, give us your philosophy on central compartment lymph node dissection. For where does it play a role here? The pendulum has swung all over the map. What's your current approach to that?
Yeah, well, some people do prophylactic. Obviously, if you have radiographic or clinical evidence intraoperatively, that patient deserves a nodal dissection. The problem with doing prophylactic central compartment dissection is that that there is no evidence that I know of for an N0 neck that prophylactic central neck dissection is efficacious. However, when a patient has a large tumor, an aggressive tumor, aggressive pathology, I think it is okay and reasonable to do a central dissection because of the high risk of nodal metastases in that setting.
Great. Terrific. And one question which comes up quite frequently, if you identify positive disease on the ipsilateral side to a tumor, how extensive of a central compartment node dissection will you do? Will you clear the entire central compartment? What's your philosophy?
I used to do that, and then I was decried in many meetings for doing that. So unless there's intraoperative evidence or imaging evidence of contralateral disease, I'll only do the unilateral side.
Great. Hey, listen, this has been spectacular. As one of our attendees has made a comment here that your lecture provides a framework for all of the younger clinicians coming up in thyroid management to understand how we got to where we are today. And I'd be remiss if I did not say that you have played an incredibly important role in the evolution of current management. And I thank you both as a friend and a colleague for all that you've contributed to our field and our fund of knowledge. So thank you. And with that, stay safe, everyone. And we look forward to seeing you next year. Many thanks to Dr. Freeman for just a superb lecture.
You're very kind. Thank you.
Take care now. Bye-bye.
Bye.